So I have the task of following Dr. Essien. Again, my name is Humberto Jimenez, and you just heard a lot of the themes that thread through a lot of my talk. But more importantly, I think throughout this pharmacoequity series that has been put together by your organization, there's been a lot of examples uh, woven through the series. A couple of weeks ago in part one, I'll actually highlight one of those examples where pharmacy, has been impacting health through innovative and effective ways, that haven't traditionally been afforded. Uh, but uh, what I'd like to do today is instead of focusing on my practice at an HIV clinic in Paterson, New Jersey, where a lot of these, opportunities and threads, I see on a day to day, I I wanted to just take a step back and have a broader view as to, the importance of health equity. Again, I'm going to piggyback on some of the themes that were discussed earlier, and for many of the things that I may be preaching to the choir too. But I think these are important themes to to further cement in a lot of our work that we do across various levels. So without further ado, I have no financial disclosures. I guess I can disclose that, like each of you, the views, beliefs, values that I have are shaped by my lived experiences and what I've learned throughout the years, which I know is only a fraction of what there is to know. But obviously, we all come with this molding of how we see things. So the learning objectives are, I hope to walk you through some of the many drivers of health inequities, on the interpersonal level, whether it's you know gaps in cultural humility, not identifying implicit biases that we all share earlier, and through other presentations and probably things that have come across your review, social determinants of health and determinants of health in general, and how that shapes health and well-being for a lot of our community. And of course, how structural racism, all of these ultimately drive some of the inequities that we struggle to try to eliminate. Also, hope that you recognize the multi-prong approach that it takes: self-reflection, proactive efforts to affect change, and how all of these plus are necessary to move the needle and ultimately begin to close some of these gaps. So we'll define health equity to, briefly kind of heard of had that eloquently discussed in the previous presentation, how social determinants of health and determinants of health, including structural components, influence outcomes. We'll briefly name some of these root causes, and where we as pharmacy, how we fit into health delivery, and from general principles to actually specific examples. Some, like I mentioned, have been mentioned before, but all of these, how they fit into our roles and our opportunities. So health equity, as defined by Healthy People 2030, is just that, as was discussed earlier: attaining the highest level of health for all people, which, as I'll discuss, includes a lot of prerequisites, right? Like valuing all people the same. I did want to highlight something that I noticed in the presentation, that there's less of a focus on the inclusion component within the presentation. But I think we should all move forward with the understanding that inclusion, which is creating a supportive environment for all people to be valued, be respected, be able to contribute fully, how you can't really untie that from equity, whether it's, the workforce or our patient population, consciously or subconsciously. It's a common thread with equity. So just wanted to make that statement. Um, and an overarching goal for Healthy People 2030, the U.S. campaign, national campaign to try to achieve health equity. Just that theme pretty much, you know, whatever specific outcome and the goal are all to achieve that ultimate equality or equity, excuse me, within health and of course well-being, having quality of life, having dignity. So in before I continue, I did want to just get some participation. Uh, Earlier, you've been privy to some of the ways that there's potential differences in outcomes, right? Atrial fibrillation was discussed and various other ones. Some that maybe haven't been named thus far. If you could throw in the chat a health condition that you have either direct exposure to or that you work with in populations where you have differences in prevalence rates or even just in outcomes, even if the prevalences are equal. If you could take a few seconds, excuse me, and throw some examples on the chat. Of course, we can spend the whole hour, a half a day, discussing these across our country, our globe, but just wanted to highlight pregnancy, maternal mortality, infant mortality, oncology, cancer, right? That there's mental health, whether it's our indigenous folks, Black, Latino individuals, in certain instances, certain conditions, not being able-bodied, other areas where you have, influx that impact clinical outcomes could be secondary to gender identity or sexual orientation. So again, we could spend the whole time on this, but I think we should all feel fairly confident that across some condition, if not many, you have differences in outcomes and or burden of disease. So I asked that because we should all, have a similar starting point or foundation, and that, well, I know me personally, when I started in my pharmacy training, much of the focus was highlighting the difference in health status or distribution of health across different groups. And that usually preceded the discussion around diagnoses, pharmacotherapy, et cetera, maybe some non-pharmacological points. But I think we have began to evolve as a healthcare community, even though, as was mentioned earlier by Dr. SCN, this is nothing new. It's not just at the beginning of the AIDS epidemic. We've known for a long time that many of these differences have existed. However, we now identify that naming that many of these differences are unnecessary, preventable, and unjust are necessary steps toward achieving equity. And I'll highlight how so in the next few slides. Some additional participation if you can open up the poll and just share what do you think, what do you believe is the most important driver of health outcomes? Is it, biological, race, ethnicity, gender, cultural, environmental conditions, social factors, your network, your family, your friends, your community? What do you do for a living? Where you live? Or individual behaviors? What do you do? It says here your host cannot vote. Okay, I'll reserve my answer to it. Okay. So B and C were the top. So most folks feel that general social, economic, cultural, environmental conditions, social factors. And I wonder how many folks, I wish I had another poll, like how many folks started their career thinking otherwise, but I'll continue. And it before I dive into this model, um, the point of the poll was not necessarily to come up with a consensus here. Um, and I think we have evolved as a community. I hope that we understand that individual behaviors, genetics, aren't the primary drivers of health. Um, I am cautiously optimistic that we're making progress here overall because I think there is some of this um, foundationally now accepted. Here in this model, it kind of delineates some of these determinants of health where in the next couple of slides I'll discuss social determinants, but just structurally, the understanding is that our health is impacted by actions outside of our control. So social, economic, political systems that drive our health. And policies within these different sectors, not primarily policies that are put in place with health purposes in mind, whether it's the labor market, housing, land, and whether or not we're directly impacting these, it's important that when solutions are being put in place or thought through, that we don't lose sight of how some of these may or may not be modifiable directly, but they'll still be contributing. And often actions that are needed on those domains are needed to enhance the side effect of health that they're having. Another component that I did want to mention across this model is how many of these factors intersect, overlap, interact together across the continuum of experiences, whether it's marginalized communities or those that are wielding power and wealth. These are often not exclusively always tied together, but the intersection and between many of these variables is unavoidable, unescapable. And for the most part, within healthcare, at a minimum, although I will discuss some opportunities for us to, as health systems, as professional organizations, to impact upstream, whether it's through advocacy or, using political capital, for the greater good. At many of our levels, whether it's interacting with patients or putting together policies or putting together a picture of how to address an issue, really social determinants of health have been what our main focus has been when we're integrating this into our model for improving health, which is awesome. And within the pharmacotherapy series, as I had mentioned earlier today and a couple of weeks ago in part one, examples were given where pharmacy and healthcare systems have developed innovative ways of incorporating information around a person's whole self and barriers to achieving goals and figuring out ways to impact and close gaps. And of course, social determinants of health is defined by condition in which people are born, grow, work, live, age, thrive, and many of the domain of within the 5 domains, many of the factors have overlapping themes, whether it's economical, transportation, health literacy, although a rate limiting step can be uniquely one versus another, which is where we sometimes have to do the work when interacting with patients or trying to address a unmet need. So determinants of health impact health. We know that behaviors can lead to some of these outcomes. We know that these social determinants of health are often built into the environment and something that folks have to navigate through and across and out of. But it goes without saying that in many instances, to address an issue this big of trying to address these expanding differences in outcomes, health outcomes specifically, as was mentioned earlier by Dr. Essien, we have to continue to ask why. Why are there disparate environmental environments, employment opportunities, educational opportunities, and that goes deeper, right? No pun intended there. And without diving that deep into each of these isms, if you will, what makes many of these health inequities unavoidable or preventable is that many of these causes, even though they're outside of our control from a healthcare provider, component, it's unavoidable to understand that many of these impact ultimately up the root to the leaves. So when I think of this and I see often insurmountable obstacles for some of our patients, I'm trying to connect the dots, figure out how am I gonna impact care from a larger sense. I feel like Charlie here from It's Always Sunny in Philadelphia, and I'm trying to wrap my brain around all of this and how can I do better within my scope, within whether it's community, my practice site, the classroom where I reside. And I just take a step back and say, all right, as a pharmacy profession, it goes without saying, first, is health equity a goal for us? And the answer should be yes. And I just wanted to highlight that in 2021, the oath of a pharmacist was updated to include specifically that we will promote inclusion, diversity, advocate for justice. But I did want to, pose the argument that for many portions of this creed, whether it's addressing the welfare of humanity or just optimizing outcomes for all patients, I practicing, interacting with colleagues and holding myself to the highest principle. I would argue that I'll take it, but this, I guess, imperative should have and does live within the rest of this oath. As many of you would attest, really practicing within healthcare, you know, aiming to achieve the highest level of health and well-being for many of those we interact with, you wouldn't be able to do without truly, visualizing the whole picture. Which, again, here it's embedded now within our oath. Last year, National Association of Boards of Pharmacy released a statement, really just acknowledging that pharmacy, has to be a part of the solution, and for us to really impact health, that we need to be more intentional about, achieving equity. The other organizations are listed here, many of them that right? So ASHP, ACCP, etc. And just briefly highlighting a few of the points that were made within that shared document. It's, again, spans pre-professional students. I names barriers to the recruitment and inclusion of those that have historically been unable to be a part of the profession. Naming not just the differences, really embedding intentionally within our curriculum and professional development programs such as these, really thoughtful inclusion of these themes as a part of the solution for improving health, with mentorship, again, recruiting, identifying metrics, benchmarking, moving forward, lobbying, advocating on the local, regional, federal level. And of course, partnerships, whether it's with other healthcare professions, medical, nursing, social sciences. I mean, our first team, all pro team has case management, nutrition, mental health, physician, nursing. So it's all hands on deck. And partnering with federal agencies to kind of empower some of the work to be done. So here are some examples of statements and position papers that began to see where and how we can achieve and really drive some of the changes within our profession, whether it's in pharmacy education, within continuing education, even just identifying programs for recruitment pre-pharmacy, and being intentional with seeing change versus hoping for it, right? So those were a couple of examples. In the chat at this time, whether it's been discussed earlier today or at the part 1 series, what are some recommendations that really put into practice, the pharmacy profession working toward achieving equity. I'll give you a few seconds to chime in. Let me open up the interpreter services, multilingual patient info. Absolutely. Whether it's upon counseling, dispensing, delivery, obviously in interactions with patients directly. And I've had my experiences with, varying degrees of success as far as culturally competent interactions, but at a bare minimum, trying to meet folks where they're at. Absolutely. I think that was one of the examples 2 weeks ago where I think in Buffalo they had put together material in various languages. Community events, I know this, and for many of us, uh, this is work that's dear to us, and we sometimes take on the tax of and the extra work. Obviously, being a part of an institution that values some of that work is good, but and it's necessary, right? But being a part of health fairs, outreach, you know, having multiple spaces where pharmacy interacts with folks, right? Not just at the hospital setting or in the retail setting, but across just being in the neighborhood. I definitely agree. Oh, all right, I'll keep rolling. So I thought I'd walk through a couple of, I guess, general themes and how we can begin to close the equity gap. And many of these overlap with some of the themes that were discussed earlier. And some of these are, I'm going to give examples of how I've embedded it into practice. But it goes without saying that, ensuring that we identify all the barriers, from when the patient is seen or registered into a clinic or seen at a bed or upon discharge through, transitions of care, whatever the setting is, that we don't lose sight of all the ways things can go wrong. As mentioned before, access to the medications, whether it's pharmacy deserts, insurance coverage or under coverage, all the ways that we can identify something going wrong and being intentional about addressing each of these, identifying, asking the questions versus just moving along to the next is an important thing that can be embedded into many of our different responsibilities and roles within the healthcare arena, right? Recognize that our shared humanity. It seems like a no-brainer, but I think that although we've made strides, we know also that in this polarized world and society, we can often see things two-dimensionally or incompletely. Um, and also, of course, checking our own biases, and I'll go into that. Um, Practicing with cultural humility, right? And what does that look like? Living with cultural humility. Um, I was told I should have been a lawyer because I like to question and be devil's advocate, but you saw earlier today in some of the reasons why we need to question, but questioning norms, guidelines, standard practice, how things are, um, and just ensuring that for the greater good that we're asking the right questions and why things are. And I'll give a couple of examples on that. And of course, just overall contributing to the ultimate goal of dismantling some of the structures, whether they're within the healthcare system, and of course, obviously, voting, just being a part of society that you would like to see yourself in, and hopefully that's one that is an inclusive one. So our shared humanity, as I mentioned, it's and understanding that our shared humanity, our experiences really shape us, uh, and ultimately that our we're all coming from different places often, but we there's a lot of similarities in what we ultimately want. Um, Being aware of implicit biases. I don't know how many folks here have taken an implicit bias test. Um, it's obviously or have how many folks have an understanding of how our amygdala or our brain is programmed to from time immemorial, from thousands of tens of thousands of hundreds of thousands of years ago to have involuntary reactions, and how that doesn't necessarily mean that that's how we got to where we are today as the civilization. So that checking some of these biases, whether it's ingrained from genetically or it's because of the 5 o'clock news and the polarized view that we have of the world, or a combination of everything that our lived experiences has given us. But we all have these biases. Uh, so really identifying where our blind spots are, questioning them, actively taking a second to before reacting when put in that situation. Seems like it's a no-brainer, but it's an active exercise, and it's not something that you'll. I know I can say I'll be able to fully reverse years of upbringing and subconscious um information, but the the more I think about it, the more I acknowledge it on the day to day or just overall through continuous honing. The goal is to to make me have a smaller blind spot when I as I interact in this world. Living with cultural humility. Again, for the for for a couple of decades now, we've at least acknowledged that practicing living with cultural competence is important, and where cultural humility steps in is in some of the limitations of cultural competence, which is basically knowing that we need to learn more about the world, cultures, values from other folks. But where some of the limitations of cultural competencies leave us, which is it's not going to be something that you can check off after a seminar or a retreat or a dissertation on Latin American studies. It's not something that can be fully achieved. That really we should frame our thinking as a lifelong journey of self-reflection, knowing we don't know, wanting to know where other folks are coming from, what their perspectives are. Again, being humble to that fact. And of course the necessary component of working toward um changing that power imbalance, some of the structures that lead to that. And that could be from our interactions with patients and meeting people where they're at versus practicing top down healthcare. all the way up to really challenging our institutions, our organizations to really think critically about its actions and its policies and the consequences, even if they're not intentional. Questioning norms. So yeah, so although we're not going to go too deep into it, I think it's a fair statement that race is a poor proxy for genetic variability. I did want to give a couple of examples, right? So in the last two iterations of our guidelines for the treatment of hypertension, recommendations have held that ACE inhibitors or angiotensin receptor blockers or ARBs are not recommended as first-line treatment options for Black patients with hypertension unless they had another condition that warranted it, like heart failure or chronic kidney disease. I did want to highlight though, questioning. So why is this the case? So I wanted to highlight two studies that led to those recommendations. So the first one compared an ACE inhibitor with amongst white and Black patients, and on the right, you'll see that although the mean reduction in blood pressure was statistically lower amongst Black individuals, these curves overlap a lot, right? But okay, it's a finding that over populations, you have a higher reduction amongst one population. The ALLHAT study compared three different treatment modalities, and also found that amongst Black participants, there was a lower reduction in systolic blood pressure in those that were treated with ACE inhibitors versus the diuretic chlorthalidone. And they did have ties to cardiovascular events. And with these two, the guidelines made the recommendation to really start with diuretics or calcium channel blockers. Okay. So providers started paying attention. And this study highlighted how, despite having adherence to these guidelines where you had folks recommended to shy away from ACEs and ARBs versus diuretics and calcium channel blockers, you still saw worse blood pressure control amongst Black individuals than non-Blacks. And actually within this study, it was emphasized how there was more intra-group variability than variability within the other variables that were reviewed. So really kind of at least started to ask the question, was one of several things to ask the question, well, should we just individualize approach to the guidelines and to hypertension for our patients? A couple of other points of contention, again, more to the story. Data conflicted on other studies had conflicting data, on ACEs and ARBs as monotherapy in Black patients. And on top of everything, the guidelines actually recommend combination therapy for folks with a higher blood pressure, which many of our patients have. So above 150 to 90, you should be using combination therapy. And actually, combination therapy was shown to be effective amongst this population, ACEs or ARBs plus another class of medication, another mechanism of action. Wrap all this up with the fact that in many of these studies, race wasn't the primary predictor of response. It was in some studies, they looked at stress levels, physical activity, obesity, low sodium intake, in observational studies, it's been shown that, yeah, the increasing doses to meet target goals were less likely to occur in some populations. So even though they were well-intentioned, outcome was driving more inequity ultimately. And over the decade that these guidelines have recommended this type of care, the percentage of Black individuals that have controlled blood pressure has decreased, despite the Affordable Care Act and many of the strides we've made on other fronts. I just highlighted one study here where it asked the question, well, if it's genetic or if there's some inherent reason why there should be a difference based on the phenotype of the skin color. And it highlighted that foreign-born Black individuals were less likely to have hypertension than American-born. So now, again, and other studies did these cohorts in various countries in Europe, in other countries that have predominantly Black individuals, Nigeria, Jamaica. And what you saw were far lower levels of prevalence in some of these other countries. So again, just questioning if some of these differences are biological, if luckily no folks weren't answering that, wouldn't you have seen some of these differences across the board? And again, just driving to some of the things that we won't necessarily get into more profoundly here, which are what are some of the systemic causes that are driving it, these determinants. Another example of race being a poor proxy is our equations, our algorithms in medicine, race-based medicine. In this example, are estimates of calculating renal function through the glomerular filtration rate, right? So GFRs, which, as we know from pharmacy, can impact dosing of medications. But the real implications are, delays in seeking specialty care, not getting on transplant lists because of, calculators, equations, not, overestimating somebody's renal function. So these were identified in the past 5 to 10, I would say 15 years as serious limitations. And without going into too much detail from these studies, I did want to highlight some of the findings from a couple of years back where the equation that we were historically using for calculating the GFR, the CKD-EPI 2009, we knew that it was overestimating renal function in a lot of our patients. And removing it wasn't necessarily doing us any favors with now was dramatically underestimating it. So it looked at other equations, a modified version, which it overestimated non-Black individuals, underestimated to a lesser degree Black individuals, but at least it wasn't overestimating. Cystatin C, which is another marker that's not routinely used because of cost, is not embedded into our structures. Labs are not readily using it. Was shown to be, again, the least accurate here, but when it was combined with creatinine in another formula, it showed to be the lesser of the evils with regards to being the most accurate for both Black and non-Black individuals. And when they looked at the likelihood of being accurate compared to a standard of care, it was found to predict at least the 30% in the 30 range, it was, again, the best option if you're able to at least have cystatin in place until better options come about. Now, ultimately, this is a step in the right direction, but this in no way should stop here because, you know, having such uh, lack of precision across, should keep us in the, on the drawing board to actually have a better tool. And at a minimum, we should be having pressure to have labs and systems use and embed more of the cystatin C within, our standard practice, right? So again, dismantling structures, all part of the journey. Some of the things that I had mentioned prior, and just taking, looking at things through new lens, whether it's for existing initiatives or brainstorming toward, new ways to kind of close the gap. And of course, using access and our positions to push change, right? Again, with interacting with patients directly, our institutions, health systems, public policy, pharmacy education. And as I mentioned before, there were great examples given in the part one of Pharmacoequity series. Pharmacy Quality Alliance is something I'd recommend you peruse. It gives numerous examples where pharmacy teams across various, I guess, settings, right? Whether it's community setting, hospital settings, um, within health insurance systems across the board, and have initiatives that all vary, that aim to bridge that gap, right? Whether it's access to or cost of medication, social isolation in rural settings, transportation, as was discussed before, like have couriers or mail order initiatives where patients are screened to identify barriers. One of the ones that was discussed a couple of weeks ago from University of Buffalo by Dr. Prescott, and here Dr. Daly, Dr. Jacobs over at University of Buffalo, um, just highlights how in their model they they use pharmacists, pharmacy technicians, delivery drivers to screen folks for barriers and really have a number of interventions again that was went into more detail a couple of weeks ago to really address the needs of the patients and the community. And finally, advocacy is something that I know we have causes that we're more passionate about, whether you're passionate about provider status or you're passionate about Medicare for all or whatever, the like we have this opportunity to advocate for equity across some of these, if not, the profession as a whole or within our health systems. And just wanted to, just drive the point home that it's a win-win, right? It's not just providing more equitable care, but being an integral part of healthcare delivery is it's good for our profession, right? I could not leave without an example of, you know, healthcare delivery within HIV, California, and several other states where access to PrEP through pharmacies, was legislated as an opportunity. This slide just highlights how upon integration of the or passing of the legislation in these states, you saw, 25%, 110% increase rates of filling within a couple of years. And it takes some coordination to make sure we don't do harm, making sure we integrate testing within some of these settings, follow up, and there's ways to even improve this further as is likely being done and studied in some of these settings. And as far as healthcare institutions, if you're working in a health system or your organization, as they grow, as they wield more power, as they need more human capital, they have the opportunity. I would argue that they have the responsibility to really to their communities that they're servicing, to not just be a beacon of tertiary care, for example, right? It's not just because of federal incentives and regulations and legislation that primary care, preventative care needs to be those gaps needs to be closed. I mean, these are opportunities to intentionally, proactively, really boost the workflow, empower folks to be a part of their system, and again, it works at the local level, it works at the state level, regional. It has to do with their workforce, has to do with empowering their communities. It has to do with addressing some of those determinants of health, right? Whether it's through food banks, whether it's through ride shares. All of these are innovative ways that aren't necessarily the way we've been doing business. Here's just one example. This is Robert Wood Johnson Barnabas, where a couple of years back they jumped on on not the bandwagon, but let's just say they saw the unmet need of you know having more community outreach um, throughout the various here. These are domains, including global health initiatives that they have. And just to sum up, these last couple hours, this equity gap is real, but it's preventable, and it's not that it's straightforward to close it, but um, we're gonna have to do it. It's something that in our lifetime, in our children's lifetimes, that we should be working toward, and it's gonna require us to be aware of this, which I think in the last couple of decades, in the last generation or two, we've seen, and we're aware, we're becoming aware, but obviously it includes action, and these are uncomfortable actions, political actions sometimes, but necessary as we've seen some of these gaps not move, widen over the years. And of course, pharmacy not just can be, we are contributors to the solution or the gap, so which is it going to be? And I hope we all are here because we want to contribute toward closing that gap. Yeah, and it's all hands on deck, right? Interacting with patients, with colleagues, in initiating policies, processes, protocols, legislation, curricula, you name it. All hands on deck, right? All right. So there are three questions. I don't know if you needed them for the CE, but I have them. But before, I'd like to pause and thank you all for your attention. And I'll pause for a couple, see if there's any questions.
Thank you, Dr. Jimenez, for your very informative presentation. We're gonna open it up for questions, and I encourage everybody to put their questions into the question box or into the chat, and then I'll read them off for Dr. Jimenez's response. So, Dr. Jimenez, I do have a question. So, just thinking about the diagram that you had from, I believe it was from Robert Wood Johnson, and looking at that diagram and thinking about pharmacy in general as practitioners, where do you think our role is in trying to close this gap, and how do you think that pharmacy programs, healthcare institutions can promote pharmacists in this way to start addressing this gap? I know that was a long question,
No,
but
that's a great question. It is multi-pronged. Well, in the part one, I mean, New York Presbyterian the group that presented on some of the work they were doing to have postpartum visits to like ensure they give guidance on how to address hypertension in mothers after birth to prevent maternal mortality, having pharmacists be a part of it, right? Um, and that presentation, Dr. Prescott's group, having having meds to bed with interaction with providers when there are issues. In the earlier talk with Dr. Essien, they discussed like not knowing what somebody's insurance status is or what they're gonna cover, right? Like, hey, I'm right here. Let me know. How can I meet you there? You should provide optimal care. We should provide optimal care. How do we work together to identify the best drug for this patient, not just with the assumptions whether or not they can get it covered? How do we make it happen, right? So like in my setting, we're always, man, it's a never ending battle discuss, working through insurances or patient assistance programs as needed. And unfortunately, this is the healthcare we have. Like in our populations, these are barriers more so in my population than in others, like as was discussed in Dr. Essien's chart with private insurance versus Medicaid, uninsured versus insured. You know, we're, just as knowledgeable as many other, folks within the healthcare paradigm to help address some of those, whether it's, navigating and troubleshooting or, you know, advocating overall through our organizations for your insert insurance provider X here, like to kind of like do better, whether it's through them directly or with our legislative, bodies here in the state, and like in New York and New Jersey or federally, like, you know, across the paradigm, we as somebody might say, get in where you fit in, right? It's through all answers, all of the above, right? At at, at our institutions, our curriculum, are we just saying that folks are different because and then moving on, or are we highlighting why early on, right? Like it's not just memorize this structure or memorize this guideline. What are some of these issues before you get to my clinic for rotation? Like it's something that I, try to impart within our curricular changes here, which isn't easy because nobody and people are not trying to change their lectures on a regular and maybe they're not comfortable oftentimes with navigating these topics. I've seen folks that meant to infuse some of this into their curriculum, for example. And I can't do that for everybody, but like I can give advice, and I'm not the only one. And I'm still learning, right? So I just know that it's okay to like, say we all need to like do better, right? And and walk side by side, if that makes sense, right?
No, it does. Thank you so much for that. I think, you kind of hit the head on the nail. What I want to do is for anybody who is, I believe we have one more question in the chat. Um, how do we professionally address coworkers' behavior that is not culturally sensitive or culturally humble? And I believe that was from one of the audience members.
Yeah, that's a great question. And I've seen that in my space here and at Rutgers and at the clinic, sometimes with our patients, some of the people that I work and that I love dearly, we all have our own experiences and our own biases, right? How do you address it? It obviously varies depending on if you can act on the spot with and in a safe way and in a way that's not going to put somebody in a defensive position. But I think whether it's at that time, if it's warranted for the safety of a patient or I think people are gonna have to be uncomfortable and we just have to have true conversations and hope that more often than not we can grow through some of those uncomfortable interactions. But naming it is unfortunately the only way some of us can identify our blind spots, right? Maybe we can identify the blind spot. Maybe somebody has to do it for me. So I might have to ask you, Kevin, like to just, put me on blast if and help me, and hopefully through our self-reflection, we can get past our own instinctual defensiveness to kind of like to be able to grow, right?
Right. Thank you for your answer. And to the audience member, thank you for that question. Again, I want to thank Dr. Eskian and Dr. Jimenez both for their time and for today's wonderful webinar.